The United States spends more on healthcare than other wealthy nations with worse results. Most concerning is that we have seen declines in infant and maternal health. But what is driving this and how do we change course? Today, we're going to be digging into the important role of data in healthcare. Today, I have with me Dr. Meg Richards, Executive Director at Panalgo, an AI healthcare analytics company that is helping to improve healthcare for pregnant women and fetuses. So let's talk with Meg about what the data is telling her and how Panalgo is improving lives. Welcome, Meg.
Thanks for having me on, Chris. I'm delighted to be here.
I'm excited to talk to you about this topic because I think this is a really, really important topic that doesn't really get enough attention and is so counterintuitive for how much, healthcare we have in this country and how much money we spend on it. It just seems like our numbers don't head in the right direction. So can you speak a little bit to why is that? Why do we see high infant and maternal mortality rates here in this country? And why are these numbers moving in the wrong direction?
Yeah, it's a great question, Chris, and it's really concerning because, as you said, the U.S. spends more on healthcare per capita than pretty much any other developed country in the world. And, but we have worse outcomes. Maternal mortality, for example, in Norway is virtually zero. And in Switzerland and other Nordic countries, it's similarly very low, almost unheard of. I think the reason it's so high in the U.S. is because we, don't have a number of policies at the federal level that mandate prenatal care, maternity leave for moms to spend time at home with their babies or dads after the babies are born, with, appropriately supportive, postpartum care. Right. We also have in the U.S. what are known as maternity deserts, where I think 1/3 of the counties in the U.S. have either limited or no access to any kind of OB/GYN care, whether that's through an OB or a midwife, doula, or even a family practitioner. And that's, when you're not getting prenatal care and you're not seen early and often throughout a pregnancy, if complications arise that complicate the pregnancy, it can have pretty disastrous consequences for both the mom and the baby.
We've had recently, I would call it a smorgasbord of laws on, sort of maternal health across the country. And, you mentioned maternal deserts and, we're seeing some places where, OB/GYNs don't feel like they can even practice effectively in these locations, and entire states are sort of being abandoned in some cases, right?
Yeah, and and Chris, that's an excellent point. That's partly the result of the Dobbs decision that overturned Roe v. Wade. In a lot of rural areas, physicians and other healthcare providers fear their ability to practice medicine freely, for concern about maybe their activities being criminalized. For example, if they need to do a medically necessary abortion, to perform a medically necessary abortion. There are hospitals that are closing down their OB/GYN units because they just don't have the providers to staff them. It's very concerning. And if you look at the forecasted statistics for babies born and providers there to help provide the prenatal care, there's a big gap.
Yeah, there's a big gap. Well, and not only that, but it's I just think across the board in healthcare, we're seeing a lot of doctors just kind of walking away from things, and we're struggling to get certain practices staffed too. So there's a lot of pressures from so many different angles.
Yes, and it's not just the maternity wards that we're struggling with staffing and resourcing, but cancer centers and cardiology practices within hospitals. Yeah. And
Yeah.
it's multifactorial, Chris, because it involves reimbursement and, the quality of life and the culture at the facility and, just all these kind of factors that come into play that make it really difficult for a healthcare provider to stay in that practice.
To be certain, it's not always just the OBGYNs that are providing maternal health care because, you could have a heart defect or you could have diabetes or you could have, mental health issues or whatever. I mean, there's a lot of different aspects of medicine that are under strain right now that all play into keeping a mother healthy through her pregnancy, right?
Exactly. And with the aging of moms, moms are
Right.
having babies somewhat later. In fact, I just heard from my daughter-in-law the other day that she is termed a geriatric mom because she's
Wow.
35. But yeah, that and with aging comes a whole slew of comorbidities like type 2 diabetes or hypertension or autoimmune diseases that
Right.
can further complicate the pregnancy. So you're right that the moms potentially need other specialist care besides an OBGYN.
And not only that, but I mean, I think, we talked about sort of maternity deserts, but there's also, sort of socioeconomic determinants of health too, right? I mean, could you speak to how that plays out as well?
Yeah, one condition that occurs in pregnancy, one complication is preeclampsia. It's a malignantly high hypertension, very,
Hmm.
very high hypertension. It can vary between a sort of a mild preeclampsia and a very severe preeclampsia. Non-Hispanic Black women are disproportionately affected by that and other complications of pregnancy because, Chris, they don't have the same access to health care as, say, their Caucasian counterparts. I think the frequency of something like preeclampsia is twice as high
Wow.
among non-Hispanic Black women as it is among white women. And
That's a huge
counterintuitively,
difference.
oh, it's
That's
a
a
big
huge
difference.
difference.
It's a big difference. Yeah. And there have been some rather well-known persons who have suffered with preeclampsia in their pregnancy. Serena Williams is one, Beyonce with her twins, and
Yeah.
so on. Um, and it's not only access to care, but there's also this thought, Chris, that there's an implicit bias that comes into play sometimes, and what is called allostatic load, the sorts of pressures that people of color, the stresses that they have to deal with every day in every facet of their lives that just contributes to these comorbidities that play into
Yeah.
further the pregnancy complications.
Yeah, and I know that. I mean, there's a lot of discussion that's been going on recently too about how the medical books are written for white, Caucasian people, and
Yes,
some diseases, some morbidities, present themselves very differently on darker skin than they do on lighter
yes,
skin.
yes.
Like skin cancers and things like that, for example, is a great example of that. So there's a lot of, unfortunately, this sort of systemic problem that we've had for a long time seems to, like we're still dealing with issues that, have risen out of the past, which
Right.
is deeply unfortunate, I think.
That continue to haunt us. Yeah, I read a wonderful interview that Serena Williams did. I think it was for Vogue or Elle magazine, where she
And
was
she, and
talking.
just to put a point on it, I mean,
Yeah.
nobody could be more fit than Serena Williams.
Oh,
So
oh,
I mean, it's not a
exactly.
matter of
Uh,
like your fitness level, for
yeah,
preeclampsia, right?
yeah, exactly. And there's a certain amount of preeclampsia that's related to obesity and
Hmm.
clearly not an obese
Not fat.
person, a very
Yeah.
fit person, as you said. But she talked, Chris, about, and I found this fascinating. She said, I'm an athlete. I know my body. And I
Right.
knew that something was wrong. I couldn't breathe. I had a terrible headache. but the staff seemed to be more concerned about her baby,
Mm,
and not, I don't think she quite said downplaying her concerns, but not hearing her.
yeah.
Yeah. And I just found that I was like, wow, Serena Williams couldn't, I mean, and she almost had a very bad outcome from that pregnancy. So
Wow. Yeah. No,
yeah.
I mean, it just goes to show you. I want to touch a little bit on Panalgo,
Hmm.
which is the company you work for, and it's steeped in data and analytics. Obviously, you guys are probably seeing just incredible things coming out of all the data you're collecting. One, like how are you collecting all this data? Where's it all coming from? And two, like what kind of insights are you seeing about all this?
So we have a closed claims data source, Chris, along with other data sources. We have a
Right.
collection of administrative claims, electronic health records, some lab data, some registry data, that we are able to offer what we call on demand or via a partnership with the data vendor. We
Right.
don't, we only own some portion of the data. The rest of it is us helping to get the data in the hands of the clients who need those data
Gotcha.
to do analytics. Mainly what we offer at Panalgo is an analytics platform called Instant Health Data.
Okay.
But we have recently come into possession of a gorgeous closed claims data set called the Mother Infant Linked Data. And what's special about those data, Chris, is that we've found a way to link the mother and the infant and multiple infants if it's a multiple birth, um, and create a mom baby pair
Ooh,
from
that's
each of
interesting.
the mothers and the babies, which is a very intuitive way to analyze what's going on in that pregnancy event and what are the outcomes for the mother as well as the fetus and then the newborn and then the infant if you want to follow them forward for a year or two, for whatever outcomes you might want to look towards.
Yeah, I love
Um,
that idea of like you can do longitudinal studies, but I love the fact that you love the data so much that you just said it's absolutely beautiful.
oh, I'm an epidemiologist by training, and we
Right.
use the word elegant a lot when you talk about a really
Sure.
elegant analysis. And yeah, these are really elegant data, and we've only come into them. We've only come into their possession a couple of months ago, but we're starting to dig really deep because there are some very interesting things that we can do that potentially haven't been closely looked at before. Um, I'll go back to preeclampsia just for a minute,
Yeah.
Chris. There's a preeclampsia registry that exists. It's an open access registry where women who are looking for more information about preeclampsia, if they suffer from that, um, can can agree to participate in the registry and just to input all their information about what happened to them and what they experienced. And it's
Yeah.
all self-reported, but women tend to be pretty good witnesses of their healthcare and their healthcare events, especially when it comes to something as important and as memorable as having a baby.
Right. Right.
Um, but we, so we, what's true about our data set, the closed claims that we have access to compared to this registry is that with a registry, you have to wait for the data to accumulate before you can interrogate the
Right.
registry with whatever questions you want to answer. Most registries are what we call prospective. In other words, you're following people forward in time. With closed claims, that kind of analysis or electronic health records, those analyses are retrospective analyses, and
Yeah.
you can get an answer almost immediately. You can look to the data and say, here's my question, and get an answer without having to wait for the data to accumulate to answer your question. So what we've done with our mom baby data is we've put it in a special module of the instant health data platform, so that you can interrogate the mom baby pair. And one of the things that we've been looking at a lot lately is preeclampsia. And
Yeah.
the reason for that, Chris, is it's a poorly understood complication.
Hmm.
We think it has something to do with abnormal development of the placenta, which then sets up a sort of an inflammatory cascade
Hmm.
throughout the rest of the body. And it can have a bad outcome for the mom and the baby. But
Right.
another thing that we've learned fairly recently is that it's having preeclampsia doesn't put you at risk just during the pregnancy event or the
Oh.
immediate postpartum period. It can set you up for cardiovascular issues for the rest of your life.
Well, because the impression had always been that once the baby was born, all the numbers returned to normal, and that's the extent of the
Exactly.
preeclampsia impact, right?
Exactly. And
Yeah.
now they're saying that preeclampsia, whenever you develop it in the course of your pregnancy, whether it's, mid pregnancy, late pregnancy, or even postpartum, sometimes you don't see it until after the baby is delivered. Um, Whenever it happens, it can set you up to have, chronic hypertension, stroke, heart failure, heart attack. So now we realize that the the preeclampsia event is kind of a canary in the mine that tells you, oh, I need to follow this woman forward for other cardiovascular complications and give her a full cardiometabolic workup that will continue even through, post pregnancy and beyond.
Well, and I would imagine, when you look at, sort of vascular diseases like we've seen recently, on a large scale like that, that could have some really different outcomes for a lot of people. I would imagine. I know there's some of these viruses, like impact pregnancy more significantly than, non-pregnant folks. And if you see how that, the vascular system is challenged during pregnancy in that regard, that could be
Exactly.
really
Exactly.
problematic.
And multiple, if you're carrying multiples, you're even more at risk because it's multiple placentas that can develop abnormally. You tend to
Right.
gain more weight with multiple babies. So yeah, there's a higher risk. But what
Yeah.
we'd like to be able to do as we interrogate the data, and what we do is we look at a group of women who experienced preeclampsia and compare them with women who did not have a preeclamptic event associated with their pregnancy. And we look to see what were the differences. And you can imagine what they are. They involve age, obesity is a big factor. Race, region of the U.S. that you live in.
Hmm.
There are some other things, pre-existing hypertension, carrying multiples, having type 2 diabetes or other kinds of cardiovascular disease. COVID caused a big spike
Yeah.
in maternal mortality in 2021. It almost doubled in the US.
Wow.
Um, Preeclampsia was only part of that, but the thought is, COVID-19, again, you're talking about inflammatory processes.
Yeah.
Yeah,
I can imagine for a pregnant person that would be very challenging.
super
Yeah.
challenging. But at the start of the podcast, Chris, you mentioned that we're an AI company. Panalgo is an AI company.
Well, the
And
algo part.
that's part of what we do. Definitely
Right.
part of what we do. But we, in addition to the core platform, we have what we call a data science module,
Hmm.
where you can use machine learning and artificial intelligence to interrogate a huge bucket of data. And our mom baby data is actually 3 million pairs.
Wow.
And you can look at predictors of a preeclampsia event or the development of severe preeclampsia using the data science module. And that's what we really want to get to, because the sooner we can identify women who may be at risk, the quicker we can devise interventions that will be put into place so that either the mom doesn't have the event at all, or if she does become preeclamptic, they can do things to mitigate the severity of the preeclampsia. Um,
Yeah.
yeah,
It,
I mean, preventive medicine is where it's at, and
for
being
sure.
able to predict. Yeah, that's what we'd love to be able to do with those data.
So let's dig in, and my understanding is you guys were recently acquired as well,
Oh, yes, by a company called Norstella, Chris. Yeah.
right? And
And we have four sister companies.
and I think I interviewed one of your sister companies that was also data analytics and sort of the drug side of things, Sightline, right?
Right,
Um,
right.
and I thought that what they were doing was really interesting, and it seems like you guys are kind of targeting a similar approach in the maternal health uh, category as well, right? I mean, because you're looking at the data that you're bringing in to help design drugs and to not create interventions and things like that. Could you talk a little bit about like the ways that what you do is used?
And that's a great way to answer you, Chris, is to talk about Norstella, our parent company's vision.
Yeah,
They talk about, our tagline is smoothing access to therapies from pipeline to patient.
right.
Norstella is truly one of those companies that aspires to and is truly able to provide support to manufacturers or sponsors or whatever you want to call them, from the time that they in-license a data asset. I'm sorry, not a data asset, a therapeutic asset,
Okay.
to the time it goes on to market and to patent expiry. Um, where Sightline plays really well, they play really well almost everywhere, and we do too. But where Sightline has traditionally been really strong is identifying trial sites and patients
Cohorts.
for
Yeah.
recruitment. Study trial density, patient density, what's going on in terms of development. They have a wonderful platform where you can get all kinds of information about who's developing what treatment for what indication, and what's the likelihood that it'll be approved, and
Yeah.
what's the competition look like. They have fabulous data. Um, Panalgo plays a little bit more in the peri post approval space.
Okay.
That is, as a manufacturer sponsor is getting ready to go to market, and maybe they're wanting to do something like stand up an external control arm for a single arm oncology trial where
Mm,
for various reasons you can't have a placebo control arm because it's not
right. Not
ethical.
ethical. Yeah.
So instead, what we can do is go into the data. We can go into our claims or EHR data and set up a comparison arm or an external control arm that can be used as a stand-in for the placebo or standard of care treatment, whatever
Interesting.
whatever that is.
It sounds like you guys are a great complement to each other. I mean, you're
Very
bringing
much so.
bringing the whole A game to the thing. So in that regard, could you speak? I mean, I imagine you've helped some of your clients do amazing things. I mean, can you speak to some of the cool success stories that you've had over the years?
We've done a ton of cardiovascular research over the years. Lately, and a lot of that is what I'd call sort of health economics and outcomes directed research, Chris. It's
Right.
it's looking at the value of treatments to not just the payers and the manufacturers and the providers, but even to the patients as well. Um, we don't have it in the United States really in a formal sense, but over in the EU, they have these health technology assessment bodies that um, look at the true value of a treatment, when you factor everything in, the efficacy or effectiveness, the safety profile, the cost, how the patients feel about it. We do a lot of that sort of work. We
Hmm.
also, in Panalgo with our data sources, do some safety signal detection and evaluation and contextualization. You
Okay.
know, sometimes because clinical trials are generally relatively small in size, if there's a rare adverse event, you may not see it in the clinical trial
Right.
setting, but you will see it in a post-approval setting when the product is, mass marketed and being used by millions of people. And we've been approached by sponsors who have said, um, we think we see this signal. We need to evaluate this event. Can you help us within a matter of days?
Right.
Because they usually have to respond to the health authorities very quickly,
I'm sure.
understandably, because the product
Yeah.
is in use and there may be, it may be causing seizures or whatever the issue
Right.
is. So we do a lot of that kind of work. I mentioned external control arms. That's something we do. Another success story, Chris, involves we've been doing quite a bit of uh, generalized anxiety and major depressive disorder
Oh,
research,
interesting.
which is an interesting tie-in to the whole mom-baby data area of inquiry because a lot of moms, generalized anxiety and depression are quite prevalent these days, and a lot of moms bring those conditions to their pregnancy or possibly develop them in pregnancy. And it's not simply a matter of not treating the mother for her anxiety or depression or reducing her dose because that could cause harm to the mom, which could indirectly harm the fetus.
Right.
Plus, pregnant moms metabolize drugs in a completely different way than their non-pregnant
Right.
selves would metabolize those drugs. So one of the things we're able to do with our mom baby data is to look at the safety of drugs in pregnancy. That's been for anxiety and depression. In fact, that's been going on for some time. So we can use the data that we have to look at the safety of anti-anxiety meds and antidepressants in a pregnant woman. Actually, a lot has been done to that end, and there's a whole list of mental health treatments that are approved for use in pregnancy, with perhaps different dosings in different trimesters, but that's the kind of thing where we've had a lot of success and are very proud of the work that we've done in that area.
When you talk about how drugs impact a pregnant woman, the fetus, and like the metabolism of a pregnant woman, the hormones, the endocrine system of a pregnant woman is going to be extremely different than like sort of the baseline. So it's really interesting that you're going to have that kind of longitudinal data too to take a look at how that impacts people. And I think it's interesting because when you talk about sort of the long-term implications of preeclampsia, what are some of the long-term implications of some of these other, like just usage of a drug and what that may, maybe that has some long-term implications down the road, that you'll tease out of the data. So that sounds really interesting.
And in much the same way that we would like to be able to build a predictive model for predicting either eclampsia or severe eclampsia, um, there's been some effort to do the same with predicting who, who among the moms are likely to develop postpartum depression.
Oh, yeah.
If depression isn't something that they bring to the pregnancy, it's possible that it could develop for the first time, post pregnancy event, and that's a real that's a heartbreaking diagnosis for both the mom and her baby. And there's a company out there, Chris. I think they're called Dionysius,
Hmm.
who has a blood biomarker test in development
Oh, interesting.
um, for predicting, to try to detect who, you know, among this group of pregnant women who's likely to develop postpartum depression based on some sort of biomarker. That's the kind of thing where we could interrogate our data, build some models within our data science module to help support the development of that blood test and also how it's targeted towards the patients who might most need to be
Well, and you
screened.
have like what, a 3.5 million large cohort to look into.
Yep,
That's amazing. That's
and
amazing
growing.
data for
Yep,
that. Yeah.
yep.
Where does Panalgo go next? Where do you've been acquired, you've got this great data set. Are you getting more data sets? Is it like where's everything headed next?
We're growing, and as you said, the data sources themselves are growing. We're accumulating more and more data over time. So, for example, the mom baby data set, when we look to see how much sort of follow up did we have on some of the babies,
Hmm.
there are some babies who are present who were born in 2018, and we can still see them in 2024. We still have information about their journey through the healthcare system, if you
Right.
will. We can see multiple pregnancies in some instances for one woman over time, over the course of time. One big point of emphasis, Chris, is linking data sources.
Mm,
So by that I mean we have a way to use what are called tokens,
right.
which are, about tokens. You can identify, Meg Richards in a closed claims data source, find Meg Richards, the same Meg Richards with the same birth date, um, in an EHR data source or even a lab data source, bring them all together to create this elegantly layered, gorgeously layered look at all of my interactions with the healthcare system.
Right.
Um, we can even we've started to do a lot of work with natural language processing of unstructured data.
Right. Yeah.
So when you're looking for clinical notes about an event that might not be, or something that isn't captured in the structured data.
Right.
For example, there are rare diseases out there that still don't have an ICD-9 or ICD-10 code, or maybe they have a code, but it's very non-specific.
Right.
There are ways to look into the unstructured data and the structured data and combine them into an algorithm, Panalgo,
Yes.
that's the name of
Yes.
our company, Panalgo, um, to get better at identifying, okay, here's somebody who we're pretty sure is suffering from Friedreich's ataxia or whatever the condition is that you're
Right.
interested in. So that linkage and that ability to layer data sources and to tap into the unstructured data to paint a very complete picture of what's happening to the group that you're following, the individual patients, and then the cohort that you've stood up is brilliant.
To put an end cap on what you're talking about there, the token helps to keep the data anonymous, but link the data across multiple data sources. So you're
Yep.
still maintaining that anonymity within the data, but getting a much richer, deeper view into it.
Exactly, exactly. It's, yeah, people talk about anonymized, pseudonymized. Anyway, it's to me, yeah, it's we're making sure that the data are secure and kept private. And we even, I think all companies do this. We have access to an expert determination person who will look at the linked data source that we've put together and make sure that we've applied great fidelity in making sure that there's nothing in those data that would help you, identify a single person.
Right.
So we do things like we mask birth dates. They might, like a birth date might get pushed to the first of the month rather than the actual day of the month.
Right. So you get
And
an
zip codes,
approximation.
exactly. And zip codes are, the first three digits, but not all five digits. And there are other things we do that the expert determination people actually take a set of calipers and look at the data and say, okay, what's the probability that an individual person could be identified? And then tell us how to correct it if they think that we need to apply any corrections.
Safe data practices are hugely important these days, right?
Yes, they are. Yes, they are.
Well, I got to say, it's really interesting, and I think it's great that you're serving a community that hasn't been necessarily well served over the years. Not adequately studied for sure, especially across all types of interventions and things like that. So I think what you're doing important work, which is really great. And I think I mentioned the fact that the maternal mortality rates and the infant mortality rates have been heading in the wrong direction in this country for some time. I feel like you're going to bring us some insights that's going to help reverse that trend and really put us hopefully where we need to be. So keep up the good work, and excited to hear about more from Panalgo.
Thanks, Chris. That's our aim, and it was a pleasure to talk about all of this with you. I appreciate you having me on.
Thanks for watching. I'd love to hear your thoughts in the comments below. And if you could, give us a like, think about subscribing, and share it with a friend. And I will see you in the next one.